Greetings and welcome to episode number 5 of the Sanity Sessions, Exploring Mental Illness and Maladaptations. I'm your host, Clint Sabom, and if you like our content, subscribe, like, share with your friends. Definitely, if you're listening in Apple Podcasts, go in there real quick where those stars are and just click on 5 stars. It'll help us go up in the rankings. Anyways, great episode today. We go deep into Schizoid Personality Disorder with Dr. Daniel Winarick. And he wrote his dissertation on this, actually. And he wrote his dissertation actually on the difference between schizoid and avoidant personality disorders. And there was a change in the DSM-5, which we'll talk about, when schizoid kind of split off into 3 different personality disorders. And we'll get into the difference between descriptive diagnostics and psychoanalytic diagnostics. We'll talk about Nancy McWilliams' psychoanalytic diagnosis, where there's a neurotic-borderline-psychotic axis measuring the degree of disturbance. We really get into the trenches with schizoid personality disorder, and this is an episode that every schizoid specialist is sure to love. So sit back, relax, and enjoy the show. Dr. Daniel Winarick, welcome to the podcast.
Thank you, Clint. Thanks for having me.
Yeah, it's great, and I'm really excited for our upcoming conversation. Do you want to give a brief introduction of yourself to listeners?
Sure. I don't know how brief it will be, but my name is Daniel Winarick. I have a Ph.D. in clinical psychology from Adelphi University. I went to Washington University in St. Louis and majored in psychology as an undergrad. I don't know if all my training experiences are relevant, but I trained at Bronx Children's Psychiatric Center, Columbia Presbyterian Psychiatric Emergency Room, and Weill Cornell, an adult inpatient center, and New York Psychoanalytic Institute. And currently I'm in psychoanalytic training at the White Institute. I've been an adjunct professor all over at LIU in Brooklyn, at Adelphi, and most recently at Queens College, where I've taught psychometric testing and intro to clinical psychology and a bunch of other psych courses. And I've been in private practice doing psychotherapy and some testing since 2017.
Fantastic. And you wrote your dissertation on schizoid personality disorder, is that right?
Yeah, that's right. In graduate school, my mentor and advisor, his name was Bob Bornstein, and he was sort of the dependent personality disorder guy. And, so everyone in this group sort of picked a personality disorder. And he told me to go, he said schizoid was a good idea because nobody really was the schizoid person. So there was an opening there. So I went with it, and, I was encouraged to sort of look for a very specific research question. So I found this controversy in the literature dating back to like 1986 about schizoid personality disorder, when its definition was changed from DSM-II to DSM-III. And people were arguing that, that it was sort of artificially subdivided into 3 different disorders in DSM-III, one of those being avoidant personality disorder. So my dissertation looked at the validity of the distinction between schizoid and avoidant personality disorders, which are very similar phenomenologically, or they look similar, but theoretically different motivations underlie the motivation for social isolation in both disorders.
Gotcha. And so up until that point, what was talked about as schizoid personality disorder could really be any one of the 3 personality disorders, the schizotypal, avoidant, or schizoid.
Correct. or really a combination of all three was, I think, more what was meant by the construct. But yeah, could be more of one or the other. Yeah, I mean, it has a very interesting history in the history of psychiatry. I don't know if you want me to go into that.
Or, go for it.
Sure.
Yeah.
Okay. Well, I guess, it sort of started with Emil Kraepelin. I don't know how to pronounce that, but he's sort of the founder of what's called descriptive psychiatry, which is what the DSM-III and after that looks like, where there's categorical diagnoses and sort of symptom lists. But he observed basically people in mental institutions, and he identified characteristics of people who went on to develop schizophrenia, which wasn't called schizophrenia back then. It was called dementia praecox. But he wrote a lot about this, pre-morbid dementia praecox personality syndrome, or the personality syndrome at risk for developing dementia praecox. And the characteristics that he attributed to this were sort of like seclusiveness, introversion, passivity, social withdrawal, and he painted a pretty good picture of the schizoid personality, and this idea that there is a specific personality type that then developed schizophrenia or was at risk for it sort of was very popular in psychiatry in the early 20th century. So one of his contemporaries kind of came a little bit after him was Eugene Bleuler, who actually coined the term schizoid. And he, just sort of elaborated on Kraepelin's definition of it. I'm just glancing at my dissertation because there are some good quotes about it.
The other thing I was curious about was right around the mid-20th century, you had R.D. Laing write The Divided Self, which was kind of schizoid to schizophrenia and describing some of the progression. I don't know if
that's interesting. I'm not that familiar with R.D. Laing's work, but that's consistent with this whole viewpoint on, schizo at risk for schizophrenia personality. So one early descriptive psychiatrist coined this construct called the shut-in personality, which I think really is the forerunner to schizoid personality. Mm-hmm. This guy named Hawk, and in 1910 he wrote that persons who do not have a natural tendency to be open and to get in contact with the environment, who are reticent, seclusive, who cannot adapt themselves to situations, often sensitive and stubborn, but the latter more in a passive than an active way. They show little interest in what goes, often do not participate in the pleasures, cares, and pursuits of those about them. Although often sensitive, they do not let others know what their conflicts are. They are shy, they have a tendency to live in a world of fancies. This is the shut-in personality.
Right. And it could progress from there to schizophrenia, or just kind of stay in that realm.
That's a great question. I mean, so either, I think. I think Kraepelin thought it was a risk factor, didn't always. But recently, schizotypal personality disorder, which is now one of the current sort of subtypes of the original schizoid PD, is viewed as sort of a protective factor against developing schizophrenia in a way. It's like you have this, attenuated form of it, but you're not going to develop the full-blown syndrome.
Interesting. And are schizoid and avoidant seen similarly?
That's a really good question. There's definitely some researchers who do. There's a whole pocket of empirical research on what are called schizophrenia spectrum personality disorders. And so they include schizotypal, schizoid, paranoid, which are all cluster A, and then avoidant personality disorder for cluster B. But I feel like, that's not the majority of researchers in the area, but there's definitely research out there that shows links between schizophrenia and those three PDs.
Sure, and you zeroed in with schizoid personality disorder and avoidant personality disorder. I'm wondering if you could just go over some of the similarities and some of the differences.
Sure. So avoidant personality disorder, so both sort of are characterized by social withdrawal and detachment, or just being like a loner, right? But avoidant PD, the motivation for the person being alone is theoretically fear of rejection, humiliation, shame, and a lot of attachment anxiety. So to avoid, getting hurt, people kind of withdraw. Whereas the way that schizoid PD was defined in DSM-IV and beyond was that the person sort of just lacked the capacity for social relationships and didn't desire belonging or interpersonal connectedness. So that really was the differential diagnosis between the two in the DSM that I wanted to test in my dissertation.
Sure. And schizotypal, how would that compare?
Schizotypal is the social isolation and detachment plus the anxiety of avoidant personality disorder plus the bizarre, I guess I would say like attenuated symptoms of schizophrenia, or the more bizarre features of it, like magical thinking or like dressing oddly, disorganized behavior. So it sort of took the schizophrenia light symptoms and the avoidant PD anxiety and the schizoid detachment and isolation. If that makes sense.
Sure, yeah, that does make sense. Now, I've heard some clinicians say that the DSM-5 of schizoid personality disorder, that most people that have the disorder don't match the kind of stark picture of this kind of cold, detached person.
Right.
A lot of them are overwhelmed by affect rather than being like cut off from affect, if that makes sense.
Yeah. I mean, that is consistent, more with the psychodynamic conceptualization of schizoid personality disorder as the detachment as being a defense against, like you said, overwhelming affect, or feeling like, you're going to merge with the other person, or like you'll lose your autonomy completely.
Right.
And so the person kind of feels safe in a sort of isolated world of their own. I mean, not like an unrealistic world, but the people like librarians, trying to think of some other good professions for schizoid people, researchers.
I heard once a White House worker, White House attendant. You just sit in the top of the White House. And
right. Yeah. Exactly. That's perfect. Actually.
Yeah. Shine the lights on boats.
Right.
Live out alone by the sea. I don't. That sounds like it'd probably be a cool job for a lot of people.
Yeah. No, definitely. But yeah, so the psychodynamic view views this detachment as defensive, whereas descriptive psychiatry views it as almost like innate or biological deficit.
Yeah, so to dig deeper into the psychodynamic view and turn to Nancy McWilliams and her book, Psychoanalytic Diagnosis, she kind of talks about the schizoid personality in these ways that it could, and it's kind of like, I guess, this is my question and how you understand her view, but it's basically a spectrum where it could be any one of those three personality disorders moving all the way to schizophrenia.
I think that's absolutely right. Yeah. I mean, I think she definitely describes like a very broad schizoid personality construct that clearly includes avoidant personality disorder in there and elaborates on sort of the defensive withdrawal in more psychodynamic ways. The fears of sort of disintegration of self or merger, can border on psychotic in severe cases. So I think she does. I think you hit it on the nail on the head, actually.
Right. So when it gets to the realm of psychotic, you're probably looking at something closer to like a schizoaffective or a schizophrenia, right?
Well, schizoaffective is a different kind of thing that with, it's sort of like bipolar disorder and schizophrenia in one. And bipolar disorder doesn't really have anything to do with schizoid. But I think definitions of schizophrenia really vary in different schools of thought. So, historically, the term was used much more loosely to refer to people, with like some sort of thought disorder who are bizarre or maybe not functional. But in sort of mainstream academic psychiatry, the bar for the diagnosis of schizophrenia, I think, is really high. And I don't know if the Nancy McWilliams, schizoid personality that ventures into psychosis would meet that bar.
Oh, okay. Yeah, that's really interesting. Like you could have a thought disorder, you could have some psychotic-like symptoms, but still just have schizoid personality disorder or avoidant personality
or
disorder.
schizotypal, yeah.
Or schizotypal and still be on the spectrum. Okay, that's interesting to know. What does McWilliams mean when she talks about the psychotic borderline neurotic axis? Is that kind of like the degree?
Yeah. Sure. Yeah. So sort of in the psychodynamic model of psychopathology, like everybody's mental functioning exists on a spectrum from normal to psychotic. And different, personality styles can be normal or borderline, meaning, at the edge between psychosis and non-psychosis, or they can be psychotic, where there's a loss of reality testing and delusions.
Okay, in borderline's kind of in the middle between.
Borderline's kind of in the middle, yeah.
Right, and what we're calling today borderline personality disorder in McWilliams speak or psychodynamic model, that would probably be in the more hysterical personality. Would that be right?
I don't know what her model of hysterical personality would be, but I think that the DSM borderline personality disorder is different than the psychodynamic borderline description, although there are similarities.
Right. Yeah, because with the psychodynamic model, you could be borderline, you could be a depressive in the borderline
right
position, or you could be schizoid and borderline, or you could be,
whatever. Yeah.
Gotcha.
But borderline is fairly severe. Borderline is also borderline, I think, in both, if that makes sense. Like borderline personality disorder in the DSM would land on the borderline descriptive axis in the psychodynamic model.
Gotcha. Yeah, right. Yeah, that makes complete sense. So, wow, moving through a whole lot of ground. What about in your clinical practice? Do you see these personality disorders we're talking about in your clinical practice?
No, that's a great question. Yeah, I mean, I get a lot of people saying they think they have schizoid personality disorder. They have this diagnosis. And some people are extremely well read about it. Like, I don't know if I'm schizoid or avoidant. And, for me, the actual label is not so important. It's sort of like whatever the person's actual problems are that I want to work with. But like I would say, broadly defined, I do see a good amount of people like in the schizoid realm, and I'm including sort of like Asperger-y types of people, which I don't want to get too much into like the autism spectrum, but there is overlap in high functioning Asperger's and the symptoms of schizoid personality disorder. So that differential diagnosis can be tricky. I don't know if it's a meaningful distinction.
With the ones that say they're schizoid or avoidant, and you think that generally fits, are they often dealing with a lot of anxiety and depression?
They're dealing with a lot of definitely a lot of depression, for sure, more so than anxiety. I think the anxiety is a little bit cut off, and the main affect is sort of shame, actually. I think in a lot of internalized shame.
Sure. Could you say more about that?
Yeah. People report feeling like, if they get into a relationship with someone, they're just going to, or anybody, they're just going to let them down or hurt them in some way. So it's better just to not try. Or that, they haven't formed relationships for so long, there's no way they can possibly do it now. Or they just, but they also, and they like being alone. So it's not easy to try to help motivate someone to go out into the social world with those factors. But people do express a desire for, the social relationships, even with this presentation. But I think the shame it's about, not feeling somehow like, you're not going to be able to handle a relationship or an interaction.
Sure. And what about functioning level? Do you see the full range of high functioning to low functioning with these?
I see mainly like pretty higher functioning because I'm in private practice and not in a like hospital type setting, where, probably people would have other problems besides schizoid personality. But
right.
Yeah, but I've seen people have very, good jobs for their syndrome. It impresses me that they find the right fit.
Okay, gotcha. And go ahead.
Yeah. Surprisingly, there's a lot of online sort of community support among people who think they have schizoid personality disorder, like on Reddit, which, I didn't know about, but when I published, an article based on my dissertation, I dropped it into that message board and got a lot of positive feedback. So I think a lot of people feel really heard and seen when, psychologists or professionals discuss this.
Yeah, and I was going to say, I would think this is a topic that so many psychologists and therapists and psychiatrists miss. Like, I would imagine that people in these categories, if they need medicine help, going to a psychiatrist, they'd sure almost positively be slapped with a different diagnosis than one of these.
Yeah. Well, I think you can have more than one diagnosis, but I don't think that the diagnosis is very rare. And someone's not going to give it unless they are very familiar with personality disorder diagnosis, or are just sort of perplexed by someone and are like searching, what could possibly fit this person. But in terms of medication, it's definitely not, in my experience with the few patients I have that fit this profile, they're not going out and seeking medication to help them, but they are definitely open and amenable to being encouraged to do so. And, there's not medication for schizoid personality disorder, but there is for depression.
Or anxiety.
Or anxiety, right.
Right. Or disorganized, or if it's typal and you've got disorganized thinking, I'm sure that, if you're kind of in the schizoid spectrum and you're and then one of these personality disorders and you're kind of in the more borderline range that psychodynamic model would see, or you might need some antipsychotic meds.
Sure. Or if you're, more in the healthier range with some disorganization, ADHD is pretty common. So is nonverbal learning disability.
Oh, that's interesting. You mean as comorbid?
Yeah, exactly.
Okay. ADHD is common, verbal learning disability.
Nonverbal learning disability.
Nonverbal learning.
Which kind of makes sense if you think about it, because that's like visual spatial learning disability, which the social world is visual and spatial.
Okay.
So people, tend to have, with that intellectual profile, tend to have difficulty with social communication. And
what about what about other like diagnoses that might be comorbid with these personality disorders?
Sure. Well, schizoid personality disorder and depression is one of the more common comorbidities, and certainly research has shown that schizoid comorbidity makes depression harder to treat. Schizoid and avoidant personality disorder are highly comorbid, which is why I thought maybe there wasn't a valid distinction, and that was sort of one of the reasons I undertook the research question, was because of the high comorbidity. Avoidant personality disorder, interestingly, people have argued that it's, overlaps so much with social anxiety or social phobia that it may not be distinct from that, and they're highly comorbid.
Interesting. I'm sure you could have trauma comorbid with these too.
Sure. Yes, but I would think trauma and schizoid PD would be fairly common because of the defensive withdrawal that, one might expect.
And after doing your dissertation work on those two, you do think it merits a distinction?
Yeah. Yeah, I do. I mean, it's not like I did some study where I went to an inpatient population with people diagnosed with one or the other. I used a sample of college students, but it was a large enough sample to, look at meaningful patterns of correlations. And just to give you a sort of quick, some overview of the results, I found that certain traits were not overlapping and were specific to schizoid, but not avoidant. And those were social anhedonia, which is a pretty interesting construct. It's the lack of ability to experience pleasure from social relationships. So to measure that, you ask people questions like, do you like playing with small children? Would you like to go on a car ride with another person for a while? Which I thought is clever. But.
Gotcha. And the schizoid would
be that predicted schizoid, but not avoidant.
Yeah. Okay. So they'd just be like, no, that doesn't really do anything for me.
Right. Like, I'm not really into puppies or whatever.
And the avoidant would probably be like, well, it depends on who it is.
Yeah. Well, the avoidant, they just didn't,
But I'm
let's see. I mean, and there's also differences between men and women, which were interesting in terms of these things. But just to find out, what did the avoidance say about social anhedonia? Yeah, there was a non-significant relationship between avoidant PD and that. So I guess they could take it or leave it.
Yeah.
And the other one, I don't know how good the empathy measure I used was, but schizoid PD was associated with lower empathy, whereas avoidant PD was not. And yeah.
Yeah, but I hear these and I kind of keep coming back to like thinking in the psychodynamic terms that if the schizoid's overwhelmed by affect, it may be not really like that they wouldn't get pleasure from social relationships. It'd just be too overwhelming.
Right. Yeah.
So,
yeah, I mean, I think that the these are like self-report questionnaires, so they're not going to be able to really tap into, I think, that dynamic, and it's also using the DSM definition. So it's not that surprising that what the DSM says schizoid is what I found.
Sure. I mean, as someone who's trained and getting more training in psychodynamic models and psychoanalytic constructs,
Yeah.
do you find yourself as that progresses getting kind of more and more down on the DSM-5?
That's a good question. So let's see. To answer it, I kind of have to go back, tell you a little bit about myself. Both my parents are psychoanalysts.
Oh, okay.
And, I grew up in New York City where psychoanalysis was still kind of cool. And then went to Wash U in St. Louis where psychoanalysis was like voodoo, in the science department. So I did develop kind of like a admiration for the DSM and sort of hard science like that, and wanting to make psychodynamic theory consistent with that or show the overlap. And went to a grad school that was really like a psychodynamic New York Yankees or something. It was like all the best psychodynamic researchers in one graduate school, and who did research on it. And most people didn't like the DSM there, but I was sort of like an advocate for the DSM and trying to argue about ways that it was consistent or not with psychodynamic theory, or at least that's what we should be talking about, because my basic view is that for psychoanalysis to sort of survive, it needed to be integrated into mainstream academic psychiatry and psychology. So, I'm not down on the DSM, but I've always recognized its limitations. But I also like, I did this externship in the psychiatric emergency room where the game is really just to diagnose according to the DSM as quickly as possible. And that was awful. But it still makes you, I don't know. It's a good question. I think I'm mixed. I honestly don't, when I'm seeing a patient, I'm not like thinking about their DSM diagnosis and having that like really inform everything I'm doing. It's like, okay, is this person generally more anxious? Are they more depressed? Are they having, personality problems or something like that?
Yeah. I mean, and that's generally what I find in talking to psychologists, that, is from a clinical standpoint, they're not really in some big hurry or, thing to diagnose somebody and just stick them in a box and leave them there. They're usually just wanting to help them and whatever.
But there are some who do. I mean, there are some who'd be like, all right, you've got borderline personality disorder. You need DBT next.
Yeah. And they'd probably misdiagnose it too.
Yeah. And the person probably feels pretty bad after.
Right. Yeah, I guess so. So, well, the other thing that comes to mind with these personality disorders is I would think there would be dissociation.
Mm-hmm. Yeah, I would too, and when I was coming up with my dissertation study, my job was to basically pick a list of variables that I thought were relevant to, schizoid avoidant personality disorders. And dissociation was on the list, but it didn't make the final cut. And I don't know why I didn't want to include it. I think it was because my advisor was like, no, don't do it. Maybe because it's more controversial or harder to measure, but dissociation certainly seems like an element of being detached and cutting yourself off from feelings and interpersonal intimacy.
Sure, and usually as a response to trauma of some kind.
Yeah. Definitely. I don't know that much about dissociation, but from a psychodynamic view, I'm definitely going to be learning about that at the White Institute, where the kind of leading thinker on it, named Philip Bromberg, wrote a bunch of incomprehensible papers. But
yeah, I'm thinking of one of the disorders in the DSM-5, the depersonalization derealization disorder, and I'm thinking that could get confused maybe with these personality disorders.
That's interesting. Yeah. I don't know the criteria for that off the top of my head, but
well, it's just a lot of dissociation and depersonalization.
Feeling like you're out of body, or
right. Yeah.
I think it's important to be very concrete. It's important to get specific and concrete about that.
Yeah. Well, I guess the part of me too that sees some overlap too is that the depersonalization, derealization has a lack of self, and that there's probably an undefined sense of self in schizoid and avoidant.
Yeah. Or the self is very fragile.
Yeah.
And at risk of, being lost. I think the ultimate fear in schizoid personality disorder is is losing oneself, basically, to another person.
Right. And what would you say that's true of avoidant too?
I don't think so. I think avoidant, the fear is, if I'm such a loser, they're going to embarrass me, and everyone's going to laugh at me if I talk to somebody.
Okay, I gotcha. And then in schizotypal, what's the core fear?
The core fear is more like it's more like a paranoid fear, like this person could be out to get me or sabotaging me in some way.
Oh, okay. Yeah, that's interesting.
Yeah. Schizotypal is interesting. I worked as a research assistant, or I don't know, postdocs. I don't know what the title was. Voluntary faculty at Mount Sinai in the Mood and Personality Disorders lab, where the sole focus of this guy, I'm blanking on his name. Larry Seeger, I think. But his whole research program was schizotypal personality disorder. And what he was doing for like 30 years was giving people with schizotypal PD oxytocin, which is a hormone that, gets released in the body when people are bonding and, experience intimacy. So the idea was that this would, reduce the symptoms of social detachment and isolation, because it would, I guess, trigger reward, more pleasure from interaction, but never
give them a little taste.
Yeah, as far as I know, that never really panned out. Larry Seever, I'm sorry, that's the guy's name, who was the schizotypal main man. But there's no one really doing schizoid PD research at academic medical centers. There is avoidant PD research.
Oh, okay. So academic medical centers would research avoidant but not schizotypal?
No, they research avoidant and schizotypal, but not schizoid.
but not schizoid. Oh, okay. Yeah, it does seem like. I mean, if there's actually stats that 1% of the population has schizoid personality disorders, there certainly seems to be a dearth of information out there.
Yeah, for sure. I mean, that's partly the way it's defined, but, so in my dissertation, out of like 120 people, let me just check. Out of 58 men, on a screening questionnaire, only two men had, scored positive for probable schizoid personality disorder, and 0 women. And there were 65 women. So out of 123 people, 2 was the N of pure schizoid.
Yeah, well, I mean, that's still like multiply,
Yeah, that's still a good amount of people. I mean, when you multiply it out.
Yeah. When you go across all of the American population, that's a.
One other just interesting finding I found was that defense style. So defense mechanisms are like a psychoanalytic construct. It's basically like a coping mechanism that's unconscious. And they're also thought to exist on a spectrum of like maladaptive to adaptive. And the adaptive ones are sometimes called mature defenses. And I found that people with avoidant but not schizoid PD traits, used mature defenses. Mature defense style was linked with avoidant PD.
Oh, okay. And then the schizoid defense mechanisms were a lot of maladaptive defense mechanisms.
Well, yeah, or they just weren't. They didn't have a consistent sort of, defense style profile.
Yeah. I would think.
Actually, no. They both. You're right. I'm sorry. I'm looking at my results. They did. They had a maladaptive defense style, and avoidant also had a maladaptive defense style, but avoidant also had an adaptive defense style.
Okay. Well, I could see schizoids doing intellectualization, which is that's kind of thought as a mature defense, is it not?
Yes, definitely.
Yeah.
Attachment anxiety was another one that differentiated the two big time.
Oh, say more about that, please.
So attachment anxiety is sort of like fears, like in close relationships, do you worry a lot about the other person abandoning you, or, worried that they're unhappy and you're trying to please them, or worried that they're judging you? That's someone who has anxious attachment. And it's almost synonymous with avoidant personality disorder, really. That's sort of the main dynamic, is anxiety about attachment.
Gotcha. And because you might see, so you might see with attachment theory, you might see avoidant personality disorder having an anxious attachment,
right?
And schizoid personality disorder having an avoidant attachment.
Yeah. Depending on what labels you use. In one model, schizoid would be like dismissive avoidant, and avoidant would be anxious avoidant.
Oh, okay, yeah, sure. That makes sense. But
McWilliams would, say that this is all schizoid.
This is still within her schizoid personality structure. Right. It's still within just different variations within it. Yeah, it's a pretty wide area that she kind of carves out.
Yeah.
Well, so do you think that these do you think that these are safely insulated from schizophrenia, or do you think like you start seeing patterns of these that they still could develop schizophrenia at some point?
I think generally they're pretty insulated from schizophrenia, but I do think it's interesting how they, sort of mirror schizophrenia, but in a much more attenuated way. So schizophrenia is conceptualized usually as consisting of positive symptoms and negative symptoms. And positive symptoms of schizophrenia are hallucinations and delusions. And negative symptoms of schizophrenia are catatonia, or like social withdrawal, detachment, flat affect,
disorganized behaviors. Probably
that's sort of a third. Yeah, I would call it negative. Some people give it its own thing, but it's more negative than positive. I don't know. That's a different question. But it's interesting to me that then there are these personality disorders that map onto that. So like schizoid does resemble negative symptom schizophrenia, and schizotypal personality disorder resembles positive symptom schizophrenia.
Sure.
But I think they are insulated and different.
Sure. What about, have you read the Masterson approach, Klein and Masterson, on disorders of the self? I don't know if that rings a bell.
It definitely rings a bell. But you'd have to remind me. Disorders of the self. There's a whole course at Adelphi on. That was the title of it.
Oh, really?
Yeah.
Okay. Well, no, it just talks about schizoid personality disorder, but I
that's sort of like as if personality or something.
Yes, yeah, and I mean it seems very along the lines of the psychodynamic understanding of it that we're talking about.
Right, which I think does emphasize the derealization and the feeling of not being really real. Because there's this idea, someone named Helen or Deutsch thought that schizoid personality was this as-if personality, like people acting as if they were human, but not really feeling human.
Yeah. And that goes back to what I was saying about depersonalization, derealization disorder.
Right, exactly.
Yeah. Which I could see those getting confused, but heck, who knows in the DSM-6 and 7 and 8? But
yeah, who knows? I don't want to see the word, the label schizoid disappear. I think.
Yeah. Talk to us about that. Is that a danger of happening?
Yeah, I mean, actually, so in DSM-5, not only schizoid but narcissistic, histrionic, paranoid, and dependent personality disorders were proposed for removal. So what was going to be left was just borderline, avoidant, antisocial, obsessive compulsive, I may be forgetting one or something, and schizotypal, which I think is just losing a whole lot of clinical knowledge. And the reasons for that were based on people's opinions on sort of how many studies have been published on each disorder.
Oh, okay. So it's just kind of like, how much can we empirically justify?
Exactly. And people are like, oh, there are no studies on schizoids, so let's get rid of it.
That's why we need people like you. We need people like you to keep schizoid alive.
I know. That's what I'm trying to do, keep the schizoid personality alive.
Yeah.
But
it got voted down anyway. There was a proposal
that they kept it. Yeah, they do not have their act together with the personality disorder section. So,
and they have a little part of where they basically say that too.
Yeah, where they say that they don't have it together, or
I mean, maybe not like that, but something to that effect.
Sure,
caveats and qualifiers.
Yeah, I mean, they took applications for all these different models of personality disorders to maybe use, and in the DSM-2 and 1, which was more psychoanalytic, it wasn't symptom lists. Each disorder was just a paragraph narrative description of what the syndrome was, which I kind of like. And there's one model that was suggested was like the Shedler-Weston approach to personality. And Jonathan Shedler writes on Psychology Today a bunch, and Drew Weston, I think, got into like political psychology. But before that, they were into establishing, empirically validated psychodynamic personality constructs, and they have derived a definition of schizoid PD based on sending out a survey to a whole, hundreds or thousands of practicing clinicians in private practice, and asking them to basically write down the traits of each of these disorders in their mind, and then aggregating them or something similar to that. And they basically came up with a construct that looked a lot like the Nancy McWilliams construct.
Okay, and that was that model was actually proposed to be used.
Yeah, it was proposed. The 5-factor model was proposed, which is just low extroversion.
Low extroversion and maybe high, and I don't know.
Nothing else.
You got a lot of conflicting impulses in these.
Yeah, I mean, avoidant PD would be low extroversion and high neuroticism.
Oh, sure, yeah.
And I suppose schizoid PD would be low extroversion and low neuroticism, theoretically.
Right.
And schizotypal would be low extroversion and high openness to experience, actually. Oh,
really? High openness in the schizotypal?
Yeah, that's the sort of psychosis-prone, big 5 trait. Too much openness to experience is associated with, bizarre thinking.
With schizotypal.
Yeah, exactly.
Oh, okay. Yeah, that's interesting. I hadn't ever heard anything of that.
Yeah.
So, as we're getting into this, why don't we put some effort into healing? What helps these people? If you treat anybody that's dealing with these or in that range, what helps them in therapy and progress?
I think what helps is really really hardcore focused attention on what they're saying, and listening, really being with them present in the moment, and not letting yourself kind of drift, because I think they may evoke that tendency in people a little bit, because they're a little bit spacey. But they have relational problems and stuff like that. I mean, it depends what the person is dealing with. They don't all come in just saying I want more relationships and I don't have any. Sometimes someone, is in a dysfunctional relationship. And I think what helps is helping them articulate their feelings and sort of just validating, their perception of reality. I think people with that syndrome tend to question, or they readily accept someone else's interpretation of what's going on. So the more you can sort of validate their own a way of seeing the world that empowers them as the sort of good construal of reality, the better.
That makes sense.
The other thing is, you want to, you can. People with this presentation are very, understanding and sort of laid back in some ways, and so you can experiment a little bit to see what works. You can suggest things. I have some fantasy that if I suggest enough good dramatic movies, that somehow that will click. That something about interpersonal relationships. That hasn't really worked. Or
that hasn't worked.
I don't. Or no, people just haven't really watched the movies. I'll
right.
Say, yeah.
This is a movie I'm not going to watch because I was told to watch it.
Yeah. But they usually don't like movies about relationships.
Right.
So.
Yeah, but I think you're onto something with that validation. Like the validation goes a long way.
Yeah, and not trying to clarify what it's like for them in relationships, or what their conflicts are. And I think there's a place for encouraging just behavior, like more directly, which is not so psychoanalytic, but it could be like just go to a bar and sit there and start talking to somebody. Can have good results with certain people, or someone. It depends on the person. I guess I'm thinking of a few different people.
Yeah.
But I mean, what I've written, I guess, before actually having practice with people with schizoid personality disorder was that, and I believe this, you want to, if they like being alone, good, and try to encourage them to do more enjoyable solitary activities.
Yeah, I would think fighting against their need for solitude would not be helpful, actually.
No, and it's not. And also, you have to be sensitive to the therapeutic relationship by, you don't want to you don't want to overwhelm the person. You sort of respect the sort of boundaries that they put in terms of relating. So I don't know if that makes sense. Like you kind of
No, it does. I mean, I guess if it was somebody that was a little too much of a take charge type A therapist with like a list of lots of things to do, that would scare them right off.
Yeah. Or they would just feel like shit for not doing it and then not come back or something.
Right.
But procrastination is kind of common. I find that they're very intelligent usually.
Mm-hmm. Probably really interesting to work with.
Yeah, I love it. And I like, it's probably not a shocker, but I certainly see some schizoid traits in myself. So we all kind of study, I think, what we see in ourselves to some degree.
Sure. Yeah. I mean, me too, I mean, I think that, and, and like the McWilliams says, they kind of all exist on an axis. So you could be not even neurotic. You could just be in the normal range and still have some schizoid traits in your personality, right?
Right. Yeah. I mean, everyone has sort of, needs more or less time alone to sort of rejuvenate or relax or process things. That's an individual difference that varies.
Right.
I also think that this idea from Winnicott, the capacity to be alone, is sort of interesting in this context. So he sort of has this theory that like the most important thing for emotional maturity and emotional functioning is the capacity to be alone, which is basically like in a relationship, you can sort of be alone in the presence of another person, like two people just sort of like reading in the same room together without the need to sort of intrude upon each other. Or you can be alone, without anyone around and still feel like you still do things adaptively and you still get pleasure out of life. And he thought that the development of this capacity was dependent on sort of early experiences as a child in terms of whether or not your caregivers basically gave you that experience of being alone in the presence of another person, or whether they were always intruding.
Yeah, I've heard that with marriages too, like a kind of idea of something that could be healthy about a marriage is living alone together.
Yeah. Well, I haven't heard that, but I definitely think that's healthy.
Yeah. Although, I hear that about Winnicott, and I always, I immediately think, well, Winnicott was an introvert. That's why he said it.
Maybe.
Like, here's the new standard, guys.
Yeah.
Doing an extra. when extroverts would be like, "What are you talking about?"
Right. No, I love Winnicott though.
Yeah. Well, we've covered a whole lot of ground. This
Certainly have
great stuff, and I've enjoyed getting to pick your brain about this category.
My pleasure, man. To me, it felt like a very niche topic, and there isn't that much published on it. So I really got into it, and that other people are interested in it is wonderful.
Yeah, well, I mean, I think there may be a niche. It may be niche in terms of what's out there written about it, but I think there's a lot of people curious about it. So I hope you keep writing about it. I hope you don't stop. Yeah.
I will. Thank you.
Okay, great. Well, thanks for being here, Daniel.
Sure. Thanks a lot, Clint.